Think of the most impressive, imposing building in your city. Chances are, it's a hospital. It might be a massive, sprawling campus covering multiple city blocks. It has a helipad on the roof. It has glowing red emergency signs visible from the highway. It has thousands of highly trained employees working around the clock, armed with the most advanced medical technology in human history. For the last 100 years, we have treated that building as the undisputed, absolute center of the healthcare universe. We have poured out money, our public policy, our educational training, and our societal prestige into it. We have built an entire national infrastructure around a single, unspoken assumption that health is something that happens inside those walls. But here is the uncomfortable, multi-trillion-dollar truth that we rarely say out loud in public health spaces. That building is fighting a war it was never designed to win. Welcome back to the Public Health Practice Gap. I am your host, Bradley Fevrier, public health educator and founder of NextGen Public Health Consultancy. If you are new to the show, this podcast explores the critical, often frustrating, liminal space between what public health research tells us works and what our institutions actually implement in practice. We look at the friction points, the economic realities, the structural barriers. Last week, we unpacked a tough reality. We looked at why prevention programs, even those backed by pristine, peer-reviewed evidence, routinely fail when they are dropped into complex organizations. We learned that evidence doesn't implement itself. It has to survive the gauntlet of organizational operations. Today, we are zooming out. We are going to expand that conversation by examining a much deeper, much older structural flaw in our health system. It is a flaw so deeply embedded in our culture that we almost cannot see it. It is the simple fact that hospitals cannot solve chronic disease alone. Yet, modern healthcare systems and society at large increasingly and unfairly expect them to do exactly that. Over the next few minutes, we are going to deconstruct how we build this hospital-centric monopoly, why the economics of it are currently collapsing under the weight of chronic illness, and what the rapidly decentralizing future of health actually looks like. Let's start with the math, because you cannot understand the public health gap without understanding the economic reality of the medical system. Today, chronic diseases, conditions like type 2 diabetes, hypertension, cardiovascular disease, chronic obstructive pulmonary disease, or COPD, and obesity account for roughly 90% of the United States' $4.5 trillion in annual healthcare spending. I want you to let that number sink in. 90%. We are not spending our healthcare dollars on broken bones and acute infections anymore. We are spending them on long-term degenerative systemic conditions. But to understand why our current system fails to manage this, I want you to think about the nature and the timeline of chronic diseases. A heart attack is an event. It happens on a Tuesday at 2 p.m. But the cardiovascular disease that caused the heart attack, this is a process. It is a slow, silent, compounding progression that develops over 20, 30, or 40 years. Chronic disease is not a virus you catch on the subway. It is a compounding interest of your environment. It is a physical manifestation of what epidemiologists call the social determinants of health. It is shaped by the micro decisions and systemic exposures of your everyday life. Let's look at the actual biological mechanism for a moment. In public health, we talk a lot about allostatic load. This is the physiological wear and tear on the body that accumulates as an individual is exposed to repeated or chronic stress. When you live in a chronically stressful environment, your body continuously pumps out cortisol and adrenaline. Over time, that constant chemical bath damages your cardiovascular system, alters your metabolism, and suppresses your immune response. So what causes that chronic stress? I'm glad you asked. It is shaped by your workplace. Are you sitting for 9 hours a day under the pressure of unattainable targets, terrified of layoffs? It is shaped by our food systems. Do you live in a zip code where we call a food swamp, where ultra-processed, hyper-palatable food is the only affordable, accessible option on your drive home from a second shift? It is shaped by urban planning and transportation. Do you have safe sidewalks? Or is your city built exclusively for cars, making physical movement a logistical nightmare? It is shaped by housing. Do you have a stable, secure, mold-free environment where you can actually get restorative sleep? These are the true determinants of chronic disease. These are the environments where the disease is manufactured. Now, look at the healthcare system we built to treat these conditions. It is almost entirely organized around hospitals and clinical settings. Hospitals are, without exaggeration, miracles of modern science. They are exquisitely, perfectly designed to treat acute illness and trauma. If you are in a horrific car accident, if you have a ruptured appendix, if you go into sudden cardiac arrest, there is nowhere else on earth you should be. They are extraordinarily effective at snatching people back from the brink of death. But, and this is the absolute crux of the public health practice gap, they are fundamentally, structurally, and economically poorly positioned to influence the everyday environments that shape long-term health. We are taking a system built for a 3-day acute crisis, and we are asking it to solve a 30-year-old environmental problem. It is the equivalent of trying to empty a flooded kitchen with a teaspoon while the faucet is still running wide open. We are praising the speed at which we are scooping the water, completely ignoring the fact that no one is walking over to turn off the tap. This structural mismatch is one of the most significant, expensive drivers of the gap between what we know and what we do. To understand how we became so completely reliant on this mismatch model, we have to look backward. We have to understand the historical architecture of modern medicine. For most of the 20th century, healthcare systems evolved squarely around the hospital. But this wasn't an accident. It was a deliberate policy choice. If we go back to the early 1900s, medicine was incredibly decentralized. Much of it happened in the home. But following the release of the Flexner Report in 1910, medical education was completely standardized around the biomedical model. We shifted our focus entirely to the microscopic level: germ theory, cellular pathology, pharmacology. We stopped looking at the neighborhood, and we started looking exclusively through the microscope. Then, following the Second World War, the United States passed the Hill-Burton Act of 1946. This is a critical piece of legislation that every public health professional needs to understand. The Hill-Burton Act provided massive federal grants and guaranteed loans to build hospitals in every community across the country. It was a noble goal, but it had a profound side effect. It physically and economically cemented the hospital as the center of the health ecosystem. Funding flowed toward these buildings in massive rivers. Medical training pipelines were built entirely around them. The brightest minds in medicine competed fiercely for residents inside their walls. Prestige concentrated at the acute care level. The trauma surgeon and the interventional cardiologist became the ultimate heroes of the medical narrative. And because the hospital became the center of the universe, our matrices for success became entirely hospital-centric. Think about how we measure success of public health interventions even today. How do we frame them to get funding? We usually frame them in relation to hospital outcomes. We say things like, this community health worker program is successful because it reduced 30-day hospital readmissions by 15%. Or, this diabetic intervention worked because it kept people out of the emergency room. But think about how incredibly narrow and frankly how tragic that perspective is. Measuring the success of public health strictly by hospital admissions is like measuring the success of a city's fire department solely by how many houses they didn't have to hose down. It completely ignores the building codes, the smoke detectors, the fireproof material, and the educational campaigns that actually kept the city safe in the first place. When we view population health solely through the lens of the hospital, we hide a massive, undeniable reality. Most of the things that keep human beings alive and thriving exist far outside the hospital's sliding glass doors. A hospital, no matter how well funded, cannot follow a patient to the grocery store to help them navigate the cereal aisle. A hospital cannot negotiate a patient's toxic, unpredictable shift work hours with their manager. A hospital cannot rewrite the zoning laws to fix the air quality in a patient's neighborhood. As long as we expect the hospital to act as the primary defense against chronic disease, we will continue to lose the fight. But we cannot just blame the culture of medicine. We have to look at the money. The public health practice gap is almost always, at its core, a financial gap. Hospitals are currently caught in a brutal economic paradox. The vast majority of healthcare reimbursement in the United States and in many systems globally is based on a fee-for-service model. Under the fee-for-service model, the vast majority of healthcare reimbursements in the United States and in many systems globally is based on a fee-for-service model. Under fee-for-service, a hospital gets paid when it does something to you. It gets paid for the MRI. It gets paid for the coronary bypass surgery. It gets paid for the amputation required by unmanaged diabetes. Every procedure has a billing code, a CPT code, and the more complex and acute the procedure, the higher the reimbursement. Do you know what there is very little reimbursement for? Not doing the procedure. Keeping the patient healthy. Spending 45 minutes counseling a patient on how to cook nutrition-dense meals on a budget. If a hospital system actually managed to cure chronic disease in its community, if it completely eradicated type 2 diabetes and hypertension in its zip code under a certain economic model, that hospital will go bankrupt. They would have to lay off thousands of workers. They would have to shutter their specialized wings. I want to be very clear. I am not saying hospital administrators are sitting in boardrooms villainously plotting to keep people sick. I work with these leaders every day. They are deeply committed to patient care. They desperately want to improve community health. But they are trapped in a business model that penalizes them for succeeding at public health. They have massive overhead. They have MRI machines that cost millions of dollars to maintain. They have thousands of salaries to pay. They need a constant flow of sick people to keep the lights on. They are tasked with solving the chronic disease epidemic, but they are only paid when they fail to prevent it. This is why, when we try to implement a beautifully designed, evidence-based public health prevention program inside a hospital, it almost always hits a wall. The hospital operations simply cannot afford to prioritize a program that actually cannibalizes its own revenue stream. So if the hospital cannot solve this, and if the economics of the clinic are stacked against prevention, where do we go? Are we just doomed to a future of endless managing chronic decline? No, because right now, quietly but forcefully, we are living through a massive structural pivot. We are witnessing the emergence of the highly distributed health system. The monopoly of the hospital as a sole arbiter of health is breaking apart. Health is increasingly being recognized not as a medical intervention, but as an environmental outcome. And because of that, health is being managed by a highly distributed network of actors who have never historically considered themselves part of the healthcare system. Who are these actors? Let's break down the nodes of this new distributed system. First, employers. We are going to do a deep dive into this next week, but employers are becoming the most critical public health actors in the country. Why? Because the cost of healthcare premiums is eating their profit margin alive. Employers dictate the stress levels, the working hours, the physical activity, the health insurance design, and the economic stability of the workforce. A company's policy on paid family leave or flexible working hours has a far more profound impact on the cardiovascular health of its employees than an annual 15-minute physical with a primary care doctor. Employers are realizing that they can no longer outsource health to the hospital. They have to engineer it into the workplace. Second, urban planners and community organizations. We are finally understanding that your zip code is a better predictor of your health than your genetic code. City planners who design protected bike lanes, who advocate for green spaces that reduce urban heat islands, and who zone for affordable grocery stores in food deserts, these people are public health practitioners. Community organizations that build hyperlocal infrastructure for social connection are actively fighting the epidemic of loneliness, which we know carries the same mortality rate as smoking 15 cigarettes a day. Third, schools. Schools shape the baseline dietary habits, physical activity norms, and psychological resilience of the next generation. When a school district decides to overhaul its cafeteria supply chain to eliminate ultra-processed foods, or when it integrates emotional regulation into its daily curriculum, it is acting as a massive preventive public health institution. Fourth, retail health providers. Look at your local pharmacy. Companies like CVS, Walgreens, and Walmart are no longer just places to pick up a prescription or buy laundry detergent. They are becoming massive primary care hubs. They are acquiring clinical groups. They are building infrastructure for biometric screening, immunizations, and chronic disease management right into the retail footprint where people already go every single week. They are bringing health to the neighborhood level. Fifth, digital health platforms. We cannot ignore the smartphone. Digital health platforms are inside our pockets. They are nudging our behavior in real time, every single day. They are tracking our sleep, monitoring our blood glucose spikes, and delivering cognitive behavioral therapy on demand. A hospital sees a patient once a year. A smartphone sees them every 10 minutes. These institutions, these distributed nodes, shape daily health behavior far more consistently and far more intimately than a hospital ever could. Now let me be explicitly clear so I am not misunderstood. This shift does not mean hospitals are becoming obsolete. We will always need trauma centers. We will always need surgical suites, ICUs, and advanced diagnostics. Rather, it means the hospital is being correctly repositioned. It is transitioning from being the center of the universe to being one incredibly vital, highly specialized node within a much broader, decentralized health infrastructure. Understanding this shift is absolutely essential if we want prevention to succeed. If you are a public health professional, a corporate leader, a city planner, or a policymaker, you must stop waiting for the hospital to solve the chronic disease epidemic. The tools to build population health are no longer locked inside the clinic. They are out here with us. They are in the corporate boardroom. They are in the classroom. They are in the city zoning committees. They are in the community center. The framework we need to adopt is something called health in all policies. It is the understanding that every major decision an institution makes, whether it is a corporate supply chain decision, a municipal transportation budget, or a school district schedule, is ultimately a health decision. If we want to close the public health practice gap, we have to start building prevention exactly where life happens. We have to design systems that make the healthy choice the default choice, long before the patient ever needs to look for the glowing red sign of an emergency room. This is a massive paradigm shift. It requires us to completely unlearn how we think about medicine and health. Next week, we are going to explore a very specific, massive dimension of this decentralization. We are going to dive deep into the role that employers are beginning to play in shaping population health. Because our healthcare decentralizes, and as chronic disease threatens the economic viability of the corporate world, employers are quietly and sometimes very reluctantly becoming major public health actors. They are shifting from seeing wellness as a perk to seeing population health as a core business strategy. It is a fascinating evolution, and it changes everything about how we design interventions. You absolutely will not want to miss it. If you want to go deeper into the economic data, the historical context, and the concepts we discussed today, I highly encourage you to subscribe to my weekly newsletter, The Next Gen Public Health Brief. Every week, we break down the structural forces shaping healthcare, population health strategy, and, most importantly, how you can actually implement these ideas in your own organization to bridge the gap between theory and practice. You can join our community of forward-thinking leaders and read the latest editions by visiting my website at nextgenpublichealthconsultancy.com. If today's episode shifted your perspective or gave you words for a frustration you've been feeling in your own work, please share it with your colleagues. Send it to a healthcare administrator, an HR director, or a community health advocate. The more people who understand the structural realities of our system, the faster we can dismantle the barriers and finally close the gap. Until next time, remember, a new episode of The Public Health Gap is released every Tuesday. This has been The Public Health Gap. I am Dr. Bradley Fevrier. Thank you for your time and your focus and the work you do.